Okay, so welcome everyone to Emma's MAHSC inaugural lecture today. I'll hand over to Matt Sutton, who will introduce Emma, and then Emma will present her talk. Please feel free to share your questions, comments, reactions in the chat as well. That'd be great. Thanks all.
Right, great. Hello, everybody, and thank you very much, Jane, for handing over. Just to show you that Emma and I are in the same room together, so it's kind of not totally virtual for us to, but we're here. So I am delighted to introduce Professor Emma Vardy. I know Emma through her involvement in the NIHR Applied Research Collaboration, but she has many other strings to her bow, which I think she's going to talk to us about. So just to give you a bit of background, she's a consultant geriatrician, and she's the lead for clinical frailty in virtual wards at the Northern NHS Foundation Trust. As well as her involvement in the Applied Research Collaboration, she's the ageing specialty lead for the Greater Manchester Clinical Research Network, and she's also the Clinical Research Collaboration Deputy Lead for Healthy Ageing theme. She's a senior editor for the journal Age and Ageing, which I know is a top journal, and also a board member for the European Delirium Association. Emma's published very widely, so she has key publications on delirium, but also acute illness in older people, on dementia, on quality improvement, and on digital themes. So delighted that Emma is a MAHSC chair, and I'm looking forward to her giving us her take on past, present, and future. Thanks very much.
Thank you very much, Matt. And so nice to see so many of you here virtually with several people in one room for some of you logging in. So thank you. My inaugural lecture, I'm a consultant geriatrician, currently based at Salford, soon to be at Oldham, work for the Northern Care Alliance, and an honorary MAHSC clinical chair since last year. And so put together this lecture, which talks about my career, going to share some of the sort of highs and lows, and also talk more specifically about some of my current research, and then talk about where I think I may be headed. That loaded comment will make sense towards the end. So my academic career, I think the quote that probably sums it up is, "Do not go where the path may lead, go instead where there is no path and leave a trail." I certainly haven't had a textbook academic career, but here I am, and I'll show you some of my journey. So I've worked in a number of different places. I'm originally from the northeast. That's a lovely picture of Dunstable Castle, one of my favourite beaches, Embleton Bay. And I think it's fair to say I'm a northern lass through and through. I trained, went to medical school in Sheffield. I did my medical training, started in Sheffield and moved to Leeds. I did specialised in geriatric medicine, and then I took some time out to do a PhD. And then I continued, went back to clinical practice, and then continued my academic career with a Walport clinical lectureship. So I was commuting across the M62 from Leeds to Salford Royal. And on completing that, I moved up to Newcastle, so closer to my roots, and was a senior lecturer there, and decided for different reasons to relocate back to Salford. And in the last sort of 2-3 years, there's been various changes and various things happened, and I'm affiliated with the University of Manchester, and I've got a picture of Oldham at the end because I'm due to start their work clinically next week. So in terms of my previous research, I think it's fair to say it's been quite varied, and my aims and direction have changed a little over the years. So I started doing some research when I was at medical school, I took a year out to do a BSc and was looking at post-mortem tissue and mRNA and amyloid precursor protein. And then an opportunity came up during my geriatric medicine clinical training to do a PhD. And so my PhD focused on taking blood samples from a number of people with dementia and people without dementia whilst I was in Leeds. And some of that work's continued because we took samples for DNA, and that contributed to an Alzheimer's Research UK genetic bank of samples. And there are publications that continue with that today that contributed to a wider piece of work. When I went over to Manchester, I gained experience in dementia diagnosis, working with a specialist neurology team with David Neary. And I was doing work on PET imaging brain studies and dementia. And also looking at sort of linking in with previous work, some of the genetics around dementia, and looking at whether there was differences in terms of some genetic markers based on phenotype of Alzheimer's disease. Moved up to Newcastle and was really interested in some of the symptoms in delirium, which is an acute confusional state due to an underlying physical illness, and the overlap with dementia and Lewy bodies. Newcastle is one of the world leading areas around dementia with Lewy bodies. And so over those couple of years, I published what turned out to be some, landmark papers that sowed the seed for some new ideas. So at the end of my time at Salford, I looked at the overlap between episodes of delirium in people with Alzheimer's disease compared to people with Lewy body disease, and found that people with Lewy body disease had an increased number of episodes of delirium in their past. And then in Newcastle, started to explore the prevalence and link with delirium in the context of Parkinson's disease, and going to recent meetings, seeing other people who've progressed that work and expanded the body of that work has been really, really satisfying to see. I had a baby amidst all of this. She's now 10. And around that time, I made a decision to move back from Newcastle to Salford. And I actually had decided that I wasn't going to continue doing research at that stage for a variety of reasons. But I got involved in looking at, there were some opportunities around developing the electronic health record to enhance it for detection of delirium. And then Salford has a really strong link with quality improvement work. And I got involved with HALO, which was an organisation affiliated with Salford at the time. And subsequently also got involved, went and did the NHS Digital Academy, because I got really interested in digital work and how that could improve care for older people. And I think throughout all of this, networking, collaboration has been at the heart, and really sort of opened various doors and led to pieces of work that I perhaps wouldn't have completed otherwise. So yes, the picture indicates, I think I reached a point in my career where I realised I needed to focus, because I've been involved in various different areas. So the theme of collaboration, I just wanted to put this in because this is a piece of work that's been really important to me, and it's a little bit of a curveball in that, so my daughter has an inherited genetic condition called PKU, and as a geriatrician and a scientist, I started to wonder about some of the aspects of PKU as people with PKU age. It's detected on the heel prick test, and the people who benefited from the heel prick in terms of treatment of PKU are now in their 50s and 60s. So basically, I did a review looking at various different aspects of aging and pulled in all these different people. It would take a long time to name them all, but they are different people that I've worked with in my academic and clinical career. And I published a paper. And if you want to know any more about PKU and aging, I did a webinar for VitaFlow recently, really conjuring and asking questions for others specifically involved in that field to hopefully work on an answer so that they're ready for my daughter when she's in her 50s and 60s. So some people, I think, in terms of my academic career, my clinical career, I'm interested, I'm curious about people, and I really like meeting lots of new people. And I've listed a number of people, and there are actually loads more that have influenced, supported me in different ways throughout my career. And I've just shown pictures of 4 of them, who probably had most influence more recently. So Maxine Power, it was the chief executive of HALO, the quality improvement organisation. She is now the director for quality improvement with the North West Ambulance Service. But she offered to mentor me, and she was really helpful. She actually gave me some really sound advice about picking a topic and focusing on it. So in terms of delirium, looking at delirium detection at the front door, and also encouraging me to complete it as well. You might not think I have a problem completing things. I've done a PhD, but because I get curious in things, and then I get a bit bored of them sometimes, it was really important to start with one project and see it to completion. Alistair McCulloch is a tour de force in terms of geriatric medicine and delirium research, and his name will pop up later on in terms of some of the work that he's done, and I've worked with him research-wise. But he helped give me advice when I was forging my research career early on, and was very generous in his support of me. And I asked him if I could do a keynote lecture for a European Delirium Association meeting. That's a top tip. Sometimes you need to ask and put yourself forward. And so I really feel that was pivotal in showcasing some of the work that I've been doing in Greater Manchester. Natalie Garrett, it was the director of innovation and research for the Northern Carolines. She's subsequently moved to another organisation, but I met her really early on in working at Salford, and she raised opportunities with me and encouraged me to apply for them, for things that I wouldn't have necessarily considered myself appropriate for. I had a bit of imposter syndrome, but she was right and encouraged me at some really pivotal parts of my career. And more recently, Chris Todd, who's the leader of the Healthy Aging Research Group with the ARC, I've not worked with Chris for very long, but it's been a really productive period, and he's really encouraged me to think outside of quite a narrow topic area and expand that. So I'm going to include also my 3 best failures. So if you have not come across the podcast, How to Fail with Elizabeth Day, I would encourage you to watch it. It has many famous people, including politicians, authors, and they all talk about their three failures and what they learned from them. So my 3 best failures are: I applied for Clinician Scientist Fellowship at the end of my Walport lectureship, and I didn't get it. And it was hard at the time, and but in retrospect, it would have been very, very time intensive. I would not have had time to really extend my research interests. And I wouldn't have ended up going up to Newcastle and then coming back down to Salford and progressing probably the QI and the digital agenda. The second best failure is I got some funding for a delirium dementia with Lewy body project through, I think it was the BRC up in Newcastle. And I called it to a halt partway through because it was not progressing as I felt it should have, which was really, really hard at the time. But it led me to reevaluating my role in academia within that particular environment, and I probably wouldn't have come back down to Salford and everything that followed afterwards. And then the final thing was I applied for British Geriatric Society president. I'm wondering, was it last year or this year, but recently, and I came close second, but I didn't get elected, which was hard at the time, and it's hard not to take that personally, but it would have taken, and rightly so, it's a really important role, and it would have taken up a lot of time that I wouldn't have been able to devote to other things, and I would have been spreading myself too thin. So in retrospect, it was the right thing to happen to me. So, sorry, I'm just going to move this band along the top because I can't see the title. Okay, I'll look at that. So the remote geriatrician, in my slides on the other screen. So I just wanted to talk a little bit more about this period of my career, because a lot of things happened to so many people, and particularly sort of clinicians during the COVID pandemic. And just before the pandemic hit, I had a diagnosis of multiple sclerosis. And so it meant that when the pandemic came along, no one was really sure of the implications, and some of the medications that I was on meant that I had to become non-patient facing. And so on the 16th of March, I came off the wards. I was looking after inpatients, and I wrote a blog, and I've looked at the timeline of this blog, and I would say, like, I became super productive. I would say there was themes of feeling really guilty because I was not patient facing and working clinically, feeling kind of a bit of a loss in terms of my role because the whole structure of my working life had imploded. And so within 2 weeks, I was writing a blog about how to work remotely. Natalie Garrett highlighted the opportunity to apply for the ageing specialty lead for the CRN for Greater Manchester, which I got, and I felt an imposter at the time, but I got that in 2020. And then the NCA frailty lead role came up in 2021, which I applied for and was successful in. And then through the CRN and trying to forge strengthen relationships between different research teams across the university and clinicians, I met Chris Todd, who then invited me quite early on to be the deputy theme lead for healthy ageing for the ARC. And then in 2022, I became the NCA lead for virtual wards for NHS at home. So it wasn't quite how I would have envisaged it, but that's what happened over a quite short period of time. So up to the present, I would say my interests, if you haven't already gathered, are very varied. It includes digital QI, digital frailty, healthcare delivery, and the list will probably extend. But at the heart is providing the very best care to older people. I'm supported in my role through the NCA. And I do have like clinical commitments, and as you've seen, leadership commitments. I guess the term is portfolio career, which is code for doing a lot of different things. So I told you I had a bit of imposter syndrome when I got the role as the ageing specialty lead, and we were, I think, Greater Manchester was 15th out of all the national CRNs, and was really proud. And this was not quite, again, I wouldn't have predicted this at the start, but two things that I focused on were building research capacity and enhancing number of participants recruited from different organisations onto the portfolio. And this is a slide of how Greater Manchester performed last year. So we became top, which was really good to see. So there's a bit, there's only one way to go after this. So we're not top at the moment for 2023 to 2024, but I'm working on that. And just as an example, so we recruited, so the Northern Care Alliance, where I work, Salford became a site for recruitment to the feasibility study, including colleagues who hadn't been involved in research before. It's a geriatrician medication review deprescribing study. And actually for the next stage, Oldham is a site, and there are other sites across Greater Manchester, including Wigan, but the NCA had not been a recruiting site for ageing research. That's been really nice to see. Another part of my role is disseminating the work that I'm doing and also making it count within the system. So I work really closely with Dementia United, which is a Greater Manchester programme of work. And I champion delirium as a work stream, and it's been really successful. And this is a slide showing the number of people with delirium detected on admission across all the different localities in Greater Manchester. So you can see that we're doing something right. And I have a picture of Helen Pratt, who's the programme manager, who works really closely with me, and we have achieved so much across Greater Manchester and engaged so many people in this piece of work, which is really satisfying. And this is the ARC GM Healthy Ageing team. Now, I was trying to put this list together, and I would say there are various affiliated members. I haven't got pictures of everybody, and I couldn't have squeezed them all on the screen, but I think it's fair to say it's a really big group. There is a variety of work going on. There has been some funding provided for dementia postdocs, which we've recruited to, and it's just so nice seeing that group grow. You might notice there's a female predominance, so it is really nice to be working and seeing women in research in practice. And yes, so that work is going from strength to strength. So my research, so delirium, for those not aware, as I said, is an acute confusional state due to an underlying physical illness. And I'm going to frame it under a talk I previously did for the Geoffrey Jefferson Centre, under how my work kind of speaks to the patient safety agenda. So this is a definition of patient safety from NHS England, and I really believe that delirium should be included, but it currently isn't. So these are the themes in relation to older people in the current NHS England strategy. So there are a number of areas that cross over with delirium, but it doesn't get a specific mention. And these are some of the questions that I have outlined in terms of how does it meet that criteria. And I will just show you where my work helps answer some of these questions. So this is not my work. This is a systematic review on falls in people in hospital with delirium, but to say there is a current piece of work being completed looking at falls in the community. And I see in my work in the community people presenting with things like falls, urinary tract infection, seemingly innocuous things like not being able to get out of a chair, but they actually have an underlying delirium with an underlying cause which needs exploration and diagnosing. Another piece of work I've done is looking around outcomes based on the 4AT, which is a tool to assess for delirium, and it gives you a score. And if you score 4 or above, that would indicate a probable delirium. And it was developed by Alistair McCulloch and colleagues. And this shows you an analysis of some data at Salford. I collaborated with Alistair and Atul Anand and other colleagues, examining our hospital-based data. And you can see the red line at the bottom, which indicates a 4AT score of 4 or above. This is a Kaplan-Meier plot showing survival curves. And essentially, and the Edinburgh data show similarly that at a year, around 50% of those will have died. You can also see that green line, which is where the person has a 4AT score of 0, which would indicate no delirium. And just below that is a line indicating people who haven't been assessed for delirium, showing that their outcomes are poorer. So they're a group that do need further assessment. And we also looked at the dosage effect of a 4AT score. And again, I've got Edinburgh and Salford data side by side. And you can see as that score increases, that the 30-day mortality increases. And there's some differences probably in terms of the population and the healthcare systems, differences between Salford and Edinburgh, but the message is the same. We've also done some work around the NEWS2, which is an early warning score system, which uses routinely collected physiological measurements is a prompt for escalated care. It was developed by the Royal College of Physicians, and new confusion was added in 2017. But what I noticed clinically was that it wasn't always scored. So we did an evaluation using our Salford data. And what this shows is that score of 4 and above, you can see that abnormalities on the new score for the confusion element, which is like the dark blue, the green and the pink, that the majority of people are being scored as being alert, and therefore it's not indicating a delirium. So what we showed is that it has low sensitivity, but high specificity for delirium. And we published that in RCP Clinical Medicine. Can we measure delirium? Yes, we can. So I created dashboards in my local care organisation, looking at prevalence of delirium, and we can break that down to ward areas. This is Greater Manchester data showing graphically what you've previously seen, showing increasing detection of delirium over the last few years. And the grey bar is a prediction based on current performance for the current year. So we'll see kind of what increase and enhanced detection there is by the end of the year. Workforce skills and public awareness. So I've done quite a bit of work working with different patient groups. There's a dementia carers expert reference group through Dementia United. I also created a film. Enid McCloy was one of my patients who described her experience of delirium. We've done public engagement events, creating zines for people to describe their experience. And we've also used World Delirium Awareness Day to get the message out to healthcare professionals and the general public. And can we improve? Well, I guess this is kind of going back to the start a little bit, the work that Maxine Power inspired. So using quality improvement methodology, we looked to increase the assessment for delirium and adapt the electronic patient record. And I was really lucky that there was also some funding through the Global Digital Exemplar through NHS Digital at the time to support that development work. And you can see here a really nice run chart showing the red line. As soon as the electronic patient record changed and had the 480 embedded, the assessment for delirium increased. And finally, some of the work that I focused on a bit more recently are inequalities in delirium. So I've been looking at non-English speaking patients, and may not surprise you, they are less likely to be assessed for delirium. Similarly, learning difficulties. And there's probably also some there are some differences that I see on a day-to-day basis in terms of clinical specialty and who first assesses that patient. And something which I'm really proud of that we've done with Dementia United is translate delirium, a co-produced, co-designed delirium information leaflet into 16 languages that covers over 97% of the languages spoken in Greater Manchester, and other organisations across the world actually are asking to use some of these resources, which is really nice to see. So the future, this slide is a bit shorter because I don't think I could have quite predicted my journey right at the start. And so I will just mention some things that I know are in my future, although quite how that will shape up, I don't have an absolutely well-defined plan. It's definitely going to involve the Northern Care Alliance and the NIHR ARC. It will certainly continue to focus on delirium, and I'm still working on raising delirium as a patient safety issue. Also been doing some work looking at other biomarkers, Delta EEG, and Salford is the third UK site to be using Delta EEG and exploring how that works in clinical practice, and also looking at community and falls. Dementia with the ARC and the postdoctoral researchers. So some of the themes are looking at deconditioning and falls prevention. As I mentioned, my clinical role is going to be moving to Oldham. I don't know if it's come across, but I do quite a lot of things. And in terms of my funded time for research, it's a day a week. So in terms of how that will shape up going forward, I don't know. Maybe a national position or a substantive research position, or who knows. I know that collaboration is the heart of the work that I do, and at the same time nurturing future generations of both clinicians and academic researchers, and succession planning for some of the roles that I currently hold, and hopefully that theme of how important I hold equality and diversity comes through as well. So some acknowledgements, probably not exhaustive, and thank you. And that's my email address and my Blue Sky handle. So over to you, Matt.
Yeah, no, thank you ever so much, Emma. And that's, I mean, your commitment really comes through. So I really enjoyed that. We're going to sort of see if other people have got questions or comments from them, but just let me start off just by asking a little bit about your thoughts about your clear commitment, sort of getting delirium on the agenda, identifying it as a patient safety issue. Why do you think kind of delirium has been so under-recognised and under-championed?
I think some of it is timing, in terms of that recognition of it being so important in all the poor health outcomes. So it's a relatively newish area in terms of research. I think because it affects mostly older people, and I think in terms of the treatment, you don't see the effect immediately. So therefore, it's quite difficult making the case for why it's important to detect it earlier. But I showed you the data that I've been working on that would help support that. I didn't show you other data that other researchers have produced, but there's certainly an indication that delirium is an insult to the brain, and it's linked with poor outcomes, including dementia. And it kills as many people as sepsis and MI. So yes, that's why I'm really passionate about it being given parity of esteem to those other areas in terms of patient safety.
Thanks. Can I just invite other people to come in, and if you've got any questions or comments that they want to make? Thanks. See, Caroline, you want to come in?
Hi, fantastic lecture. Thanks so much, Emma. I was just going to ask, you know, there's so much in there in terms of what you've done already, what you've achieved. It was lovely to see you mention failures as well, by the way, because I think that's the part of everybody's pathway, and how much we in the end get from those failures as well. I was just thinking of some of the great achievements that you mentioned. One of those I thought was brilliant to see what you're doing around inclusive research and, you know, dissemination and the translation of outputs, you know, to make them accessible to wider communities, and think that that's a fantastic example of what, you know, that I guess has learning for other projects. So I just wanted to ask about that, your work around co-production and doing that kind of work. Have you published and shared some of that, you know, approach that you've taken and how you've done that?
I guess not published through the traditional route, and that's one thing I've learned. And the traditional route is what counts, isn't it? In terms of, because I'm employed by the trust as opposed to university, there's perhaps a little bit less pressure in terms of that publication academic journal, so we can get the message out there in different formats. So I would say those materials are out there, and there is communication around it using other portals such as, well, the Dementia United website, which is so well curated, and we know that it's getting visibility because we've had teams from Singapore and Canada getting in touch about the work. I think also that local dissemination. So I think that's where working with Dementia United has been so important, in terms of them working with communities, and communities really engaging and enthusiastic when people are taking an interest in trying to help raise awareness of conditions and reduce those health inequalities. So been really fortunate. That's probably why we've had so much engagement in terms of helping with connecting up with the right organisations to work on translations, and then making sure that those translations actually work, and getting feedback that a written leaflet is not going to work as well as like having something in spoken format in terms of video. And I have done some smaller pieces of work with various students around looking at under-detection in groups such as non-English speaking and learning difficulties, and I haven't published it, even though I'm really passionate, and I'm always encouraging people to write things up and not presume that they are published. But that is something that because I haven't gone through that traditional route, and I now suddenly find myself part of like a really big research group, but that's only been the case for the last 2 or 3 years, I've realised that I can only stretch myself so far, and I need to capacity build in terms of my own sort of team. And that's where, you know, in terms of funding from the Alzheimer's Society, the postdoctoral positions, hopefully going to make some of that a little bit easier, because I probably wouldn't be the first researcher to do something and it doesn't get written up, but you've kind of bumped it up in terms of my priorities because I do need to write it up.
Great, thank you.
So you've added to Emma's to-do list now, Carol.
Yes.
I can see that Lloyd Gregory's put a comment and a question in the chat. So he just says, great lecture, Emma, thank you. Can you tell us a little bit more about your work in the digital space?
Oh, yes. So becoming part of an organisation that had an embedded electronic health record, and it was a case of, I'd say, the stars aligning, right place, right time. So in terms of Salford and the electronic health record, the global digital exemplar, meeting and working with Rachel Dunscombe, I could really see opportunity there. And I think it's obviously led to further opportunities in terms of once you start capturing some of that information for clinical purposes, before you know it, you have a very large data set to explore. And although it might seem a little bit of a curveball in terms of doing the NHS Digital Academy, it emphasised to me the importance for geriatricians to be involved in the digital space, and also as a woman to be involved in the digital space, because digital does tend to attract certain specialties more than others, and it does tend to be a bit male dominated. And so it's given me skills that have helped me connect up with fellow geriatricians. So there's now a GeriData group that's part of the British Geriatric Society, and we've been writing up work and really creating a bit of a sort of call to action around digital and how we can enhance care for older people. But the other thing that I got out of NHS Digital Academy, I know this wasn't what you asked, but it taught me to write because we had a number of assignments, and it probably taught me best how to write, to do academic writing, which has been really helpful and probably led me to be more, it's definitely led to me being more productive in terms of some of the other pieces of work, such as, you know, the blogs that I've written, etc.
Great, thanks, Emma. Okay. Jane, I think we probably do need to call it to a close, don't we, I think? But
yeah.
Can I say thank you to everybody. There's lots of familiar faces. I can see many familiar names as well. So thanks ever so much for joining us. And if we could just say many thanks to Professor Vardy, please. So.
Congratulations, Emma.
Thanks for all for joining.
Thanks, everyone. Take care.